Okay, let's unpack this. I want you to visualize something for me. Just close your eyes for a second, unless you're driving, of course. You are standing in the exam hall. The air conditioning is humming that low, ominous hum. Your palms are slightly sweaty. You are standing at the foot of a hospital bed.
The arena.
The arena, exactly. And in that bed is a patient with a massive, hard spleen you can feel from across the room, veins radiating from their umbilicus like snakes, and a history of vomiting blood. And staring you down over his half-moon spectacles is the external examiner. He hands you the chart and says, "Doctor, this is a case of portocaval obstruction. How do you plan to anesthetize this patient for a proximal leonorenal shunt?"
That is the moment. That is the moment where you either crumble or you shine. That is the classic long case. It is the absolute Everest of the MD anesthesiology clinical exam, particularly, as you said, for the Gujarat University boards.
And that is exactly why we are here today. We aren't just reviewing a topic, we are simulating a high-level prep session. You are the senior faculty member, I am the postgraduate student, and we are going to tear this topic apart. We are talking about portocaval obstruction, or PCO, and the anesthetic management of portosystemic shunt surgery.
Right. And we need to be precise, we need to be clinical, and we need to avoid the traps that examiners absolutely love to set. We have a massive stack of sources today. We're pulling from Miller's Anesthesia, 10th edition for the management, Harrison's Principles of Internal Medicine for the classification, Robbins for the deep pathology.
And of course, BD Teresia.
And of course, BD Teresia, because, you know, the Viva always starts with anatomy.
Always. And we've also layered in some exam-specific stuff like long and short cases in anesthesiology and the objective anesthesia review, just to make sure we hit those keywords they're looking for. So the mission today is simple. Synthesize this complex mess of anatomy, altered physiology, and high-risk surgery into a structure that answers that dreaded 20-mark theory question and, well, navigates the Viva without falling into a hole.
Let's do it. Let's begin at the beginning. Part A, Introduction and Basic Concepts.
Okay, so if I'm standing there in the exam, or maybe I'm starting to write that 20 marker, how do I frame the introduction? It seems simple, a blocked vein, but I feel like there's more nuance here that they're looking for right from the start.
There is. You have to start with precision. Portocaval obstruction, or PCO, is fundamentally an obstruction to blood flow in the portal vein. That's the definition.
Yeah.
This obstruction is the primary driver of portal hypertension. Now, here's the key clinical context. While cirrhosis is, the most common cause of portal hypertension globally, when the exam specifies portocaval obstruction as a long case, they're often nudging you towards something else. They're hinting at extrahepatic portal vein obstruction, EHPVO, or non-cirrhotic portal fibrosis.
Okay, so why does that distinction matter to me as the anesthetist? I mean, isn't a blocked liver a blocked liver?
Not at all, and that's the first trap. In EHPVO, the liver cells themselves, hepatocytes, are often working perfectly fine. It's just a plumbing problem leading to the liver. In cirrhosis, the plumbing is bad and the factory is shut down. The hepatocytes are sick. That completely changes your drug metabolism, your coagulation profile, everything. So the first question you have to ask yourself is this a flow problem, a function problem, or both?
That's a key distinction right there. So I shouldn't just jump to the conclusion liver failure immediately. It's a flow problem first.
Precisely. And the next question the examiner will ask, either out loud or in their head, is, why do we, as anesthetists, care so much?
Mm-hmm.
And the answer is, we care because this flow problem creates a multi-system disaster. You are managing a patient with a hyperdynamic circulation, profound coagulopathy, and the ever-present terrifying risk of massive hemorrhage. You are managing a patient who is physiologically brittle.
Looking at the past papers, this topic seems to pop up in 3 specific ways.
It does. It's a classic. First, you have a long question. Describe the pathophysiology and comprehensive anesthetic management of a patient scheduled for a leonorenal shunt. That's your 20 marker. Second, you'll see it as a short note, usually asking about a specific complication like hepatorenal syndrome or a scoring system like the Child-Pugh classification. Yeah. And finally, the Viva. And the Viva will almost always start with anatomy.
Which brings us right to it, anatomy. You mark this in our outline as very high yield. So the examiner hands me a piece of chalk and says, draw the portal circulation. What am I drawing? What are the critical points I have to hit?
You are drawing the union. According to BD Teresia, the portal vein is formed by the union of 2 specific major vessels, the superior mesenteric vein, or SMV, and the splenic vein.
And location is everything in surgery, right? So where does this meeting happen?
It happens behind the neck of the pancreas. That's the landmark, usually at the vertebral level of L2.
Why is that specific landmark behind the neck of the pancreas so critical for us to know?
Well, think about the surgery. If they are doing a shunt, they are dissecting right there. The pancreas is a soft, angry organ. If the surgeon is digging around behind the pancreatic neck to find the vein, the risk of iatrogenic pancreatitis post-op is very real. Also, knowing the L2 level helps you visualize the other retroperitoneal structures involved. And you also need to draw the tributaries, the gastric veins, the cystic veins. These are so important because they become the escape routes, the pathways for the collateral circulation, the varices, when the main road is blocked.
Okay, I've got the anatomy down. Now let's talk blood supply. The liver is unique because it has this dual blood supply. This always feels like a bit of a trick question in the first year of EVA.
It's a physiological cornerstone, not a trick at all. It's fundamental. The liver receives about 75% of its blood flow from the portal vein. Now, this blood is deoxygenated, but it is incredibly nutrient-rich because it's coming straight from the gut after a meal. The remaining 25% of the flow comes from the hepatic artery, and that is your standard oxygenated arterial blood.
So the vein is doing the heavy lifting in terms of sheer volume. But what about oxygen? I mean, usually veins are just carrying used blood back to the heart.
That's the paradox, and it's a huge point. Even though the portal blood is deoxygenated relative to arterial blood, because the volume is so massive, 3 times the arterial flow, the portal vein actually provides 50% to 60% of the liver's total oxygen requirements.
Wow. That is a huge number. So if we have a portocaval obstruction, or even if the surgeon just clamps that vein during the shunt procedure,
Yeah.
we are effectively strangling half the liver's oxygen supply. Is that right?
Exactly. You got it. And this brings us to probably the most important physiological concept you need to know for this entire exam and honestly for your career, the hepatic arterial buffer response, or HABR.
Yes, I see this acronym everywhere in Miller. Let's really drill down into this. How does this buffer actually work?
Think of it as a beautiful reciprocal relationship, a safety net. The liver craves constant blood flow and oxygenation. If the portal vein flow drops, say, due to an obstruction or a surgical clamp, a substance called adenosine accumulates in the space around the vessels, the space of Moll. This adenosine is an incredibly potent vasodilator. It specifically causes the hepatic artery to dilate, which dramatically increases arterial flow to buffer the loss of portal flow and maintain oxygenation.
So it's a backup generator. Portal flow goes down, the artery ramps up to save the day.
Yes. But here is the critical anesthetic relevance. This mechanism is fragile. Many of our drugs, specifically the older volatile anesthetics like halothane, can blunt or even completely abolish this response. If you use a drug that knocks out the buffer and then the surgeon clamps the vein, you have induced ischemia. The liver takes a massive hit it might not recover from.
That is a clinical pearl right there. Wow. Okay, we'll get to drug choice later, but that explains why agent selection isn't just a matter of preference, it's a matter of physiology.
Let's talk numbers for a second. What is high pressure? What are we trying to fix? It's right. Normal portal pressure is surprisingly low, just 5 to 10 millimeters of mercury. We define portal hypertension when the gradient, that's the hepatic venous pressure gradient, or HVPG, is greater than 5 millimeters of mercury.
But 5 doesn't cause bleeding, does it? It's just the definition.
No, exactly. You need to cross a threshold for complications to arise. The magic number you'll see in Harrison's, and the one you need to quote for the exam, is 10 to 12 millimeters of mercury. Once you cross that 12 mmHg mark, the collaterals are forced open, the varices form, and the risk of rupture becomes real. That 12 mmHg is the pressure the surgeon is trying to get below.
Okay, that's a perfect foundation. We have the anatomy, the pressures, and the safety net. Now let's move into Part B, portocaval obstruction and portal hypertension, specifically the classification. Harrison's loves a good table. How do we structure this for the examiner so it's clean and logical?
Stick to the anatomical classification relative to the liver sinusoids. It's the cleanest way. Prehepatic, hepatic, and posthepatic.
Okay, let's blitz through these. Prehepatic, what does that mean?
Blockage before the blood even gets to the liver. The classic example is portal vein thrombosis. This is your healthy liver blocked pipe scenario. You often see this in hypercoagulable states or after intra-abdominal sepsis like omphalitis in newborns, which can manifest as EHPVO years later. Also, splenic vein thrombosis, which is a classic complication of severe pancreatitis that walls off the vein.
Okay, and hepatic, the problem is inside the liver itself.
Right. And this is the liver itself. We can even subdivide this further for extra marks into presinosoidal, sinusoidal, and postsinusoidal. Sinusoidal is the big one. That's cirrhosis. Alcohol, hepatitis B, hepatitis C, fatty liver disease. That accounts for the vast majority of cases worldwide. Presinosoidal gives you things like schistosomiasis, which is a huge issue depending on your geographic region, or congenital hepatic fibrosis.
And finally, posthepatic.
Blockage after the liver. The classic textbook cause is Budd-Chiari syndrome thrombosis of the hepatic veins as they drain into the IVC. But don't forget the heart. This is a common Viva trap. Severe right heart failure or constrictive pericarditis creates a massive back pressure that transmits all the way down the IVC into the hepatic veins and congests the liver.
So if I have a patient with ascites and a big liver, I need to look at their neck veins, the JVP, to rule out a cardiac cause.
Always. If the JVP is sky high, the primary problem might be in the chest, not the abdomen. That is a classic physical exam trap that separates the good candidates from the great ones.
Perfect. Now let's get into the weeds. The pathophysiology, this is essential. Why does the pressure actually go up? Is it really just a blocked pipe?
No, and this is where you can really distinguish yourself in the exam. You need to explain the two-hit hypothesis that you'll find in both Robbins and Miller. It's not just one thing.
Okay, walk me through the two hits. What's hit number one?
Factor 1 is increased resistance. This has two parts. First, there's the obvious structural damage fibrosis, regenerating nodules that are physically compressing the veins. The architecture is destroyed. But there is also a dynamic component. The hepatic stellate cells, which are normally quiescent, become activated and contract, causing active vasoconstriction inside the liver. The vessels themselves are squeezed shut.
Okay, so the road is narrow and bumpy. That's resistance. I get that. What's hit number two?
Factor 2 is increased flow. This is the great paradox. You would think if the road ahead is blocked, the traffic leading to it would slow down. But in portal hypertension, the exact opposite happens. The splenic vessels, the arteries feeding the gut, the spleen, the pancreas, dilate massively. They start pumping more blood into an already congested system.
Hang on, unpack that for me. Why on earth would the body dilate the gut vessels if the liver outlet is blocked? That seems completely counterintuitive.
It is. And the answer is the nitric oxide paradox. In the systemic circulation, and especially in the gut, there's a massive overproduction of nitric oxide, a potent vasodilator. This is likely driven by shear stress on the vessel walls and, crucially, something called bacterial translocation.
Bacterial translocation? What's that?
Yes. The gut wall becomes edematous and leaky because of the venous congestion. Bacteria and their products, like endotoxins, leak from the gut lumen into the portal circulation.
The body's immune system responds to this by releasing a flood of inflammatory mediators and vasodilators, including huge amounts of nitric oxide right there in the splenic bed.
So we have high NO in the gut causing this massive vasodilation.
But, and here's the paradox, inside the diseased liver, there is a deficiency of nitric oxide synthase. There's not enough NO. This leads to relative vasoconstriction inside the liver. So you have a fire hose, that's the high flow from the gut, aimed directly at a pressed wall, that's the high resistance in the liver. That combination is what creates the explosive pressures of portal hypertension.
That is a fantastic explanation.
Yeah.
I never really connected the bacterial translocation directly to the vasodilation before.
Yeah.
Makes so much more sense now. And this Splenic vasodilation, this is what drives the whole hyperdynamic circulation we see clinically, right?
Exactly. This is the absolute hallmark of the patient with significant liver disease. The gut vessels dilate, so the total systemic vascular resistance, the SVR, drops. It just plummets.
Okay, so the afterload on the heart is low, and the blood pressure wants to drop.
Right. The body senses hypotension, so the heart compensates. It beats faster and it beats harder. You get a high cardiac output state. Clinically, the patient is warm, they have bounding pulses, tachycardia, but, and this is absolutely critical for us, the effective circulating volume is low. The blood is pooling in this huge, dilated splenic reservoir. It's not in the central circulation where it's needed.
So the body thinks it is dehydrated or in shock.
Yes. Exactly. The kidneys sense low effective pressure and they scream, "We are in shock." What do? They activate the renin-angiotensin-aldosterone system, RAAS. They hold on to every last drop of salt and water.
So the patient is total body fluid overloaded. You see it as ascites and peripheral edema, but intravascularly, in the arterial tree, they're actually underfilled.
Starving in the midst of plenty. That is the hemodynamic profile you are managing in the operating room. It's a paradox you have to constantly keep in your mind.
That sets up our fluid management strategy perfectly. We can't just flood them with crystalloid because they are already overloaded and it will just leak out as more fountains. But we can't let them run dry either because their effective volume is dangerously low. It's a real tightrope.
It is the central challenge of this entire case. Absolutely.
Okay, let's look at the patient again. Back to the bedside. Part B, Section 5. Clinical features. We mentioned the massive spleen. Why does it get so big?
Purely congestion. The blood from the spleen drains via the splenic vein into the portal system. If that system is blocked, the blood backs up and the spleen just gets engorged. But the clinical relevance for us is hypersplenism. The enlarged, congested spleen becomes hyperactive. It turns into a graveyard for blood cells. It sequesters platelets and red blood cells. So clinically, you see thrombocytopenia and anemia, which has huge implications for bleeding and anesthesia.
Okay, which complicates our regional anesthesia options and our transfusion triggers, which we'll get to. What about the ascites? We know the mechanism now, high portal pressure plus low albumin plus RAAS activation. But what does a tense, fluid-filled abdomen do to the lungs?
It's a mechanical disaster. A tense abdomen pushes the diaphragm upwards. This crushes the bases of the lungs and dramatically reduces your functional residual capacity, or FRC. These patients have almost no respiratory reserve. They desaturate incredibly fast upon induction of anesthesia. It also predisposes them to gastroesophageal reflux and aspiration. They are always a full stomach.
And the varices. These are the ticking time bombs.
Yes. Esophageal and gastric varices are the most dangerous. They're just thin-walled, dilated veins sitting right under the mucosa, exposed to acid and high pressure. If they rupture, it's a catastrophe. You might also see Caput Medusae. This is the recanalization of the umbilical vein from birth, resulting in those dilated snake-like abdominal veins radiating from the umbilicus.
And finally, the brain. Hepatic encephalopathy. What's the simple mechanism here?
It's due to portosystemic shunting. The blood from the gut, which is full of toxins like ammonia, bypasses the filtering function of the liver. The toxins go straight into the systemic circulation and up to the brain. Ammonia, in particular, causes astrocyte swelling and cerebral edema. Clinically, look for confusion, disorientation, the classic flapping tremor called asterixis, and that sweet, musty breath smell known as Fitter hepaticus.
Okay, that really sets the stage. We have a patient with bad plumbing, a hyperdynamic but struggling heart, compromised lungs, no clotting, and a toxic brain. And now the surgeon says, we need to operate.
Yeah.
So, Part C, portosystemic shunts. What is the basic objective here? What are we trying to achieve with this surgery?
The objective is purely hemodynamic. It's a plumbing fix. We want to create a bypass, a low-resistance channel, to divert blood from the high-pressure portal system into the low-pressure systemic venous system. The goal is to lower that portal pressure below 12 millimeters of mercury to stop the varices from bleeding. That's it.
The outline lists types of shunts as an exam favorite. We absolutely need to know how to categorize these.
You do. And the simplest way is to categorize them as total, partial, and selective shunts.
Let's start with total. Sounds dramatic.
It is. The prototype is the end-to-side Portocaval shunt. The surgeon literally cuts the portal vein and sews the end of it directly into the side of the inferior vena cava, the IVC.
That sounds incredibly effective at dropping the pressure.
It's too effective. That's the problem. It diverts all of the portal blood away from the liver. The liver gets zero portal flow. It has to rely entirely on that 25% of flow from the hepatic artery. The rate of postoperative hepatic encephalopathy is massive because none of the gut toxins are being filtered anymore. It solves the bleeding, but at the cost of essentially rotting the brain. These aren't really done anymore.
So that led to the development of selective shunts. This is the gold standard for the written exam, right? The one they love to ask about.
Absolutely. The distal splenorenal shunt, or DSRS, also famously known as the Warren shunt, this is brilliant surgical engineering. The surgeon disconnects the splenic vein from the portal system and connects the distal end of it to the left renal vein.
Okay, so why is that so much better?
Because it's selective. It selectively decompresses the varices, which drain into the splenic vein via the short gastric veins, but, and this is the key point, it leaves the main portal vein and the superior mesenteric vein intact. So the liver still receives that nutrient-rich blood flow from the gut. You stop the bleeding, and you preserve liver perfusion. The incidence of encephalopathy is significantly lower.
That sounds like the perfect solution. But practically speaking, do we see these performed often today?
In exams, yes. You must know it inside and out. In reality, much less so. It is a technically very difficult and long operation. The renal vein and splenic vein are often far apart. The dissection behind the pancreas is tricky.
And that's why TPS has become so popular.
Exactly. The transjugular intrahepatic portosystemic shunt. This is done by the interventional radiologist, not the surgeon. They go in through the jugular vein in the neck, navigate down into the liver, and use a stent to create a track, a shunt, directly through the liver tissue, connecting a branch of the portal vein to a branch of the hepatic vein. No open surgery. It's often used as a life-saving measure for acute bleeding or as a bridge to transplant.
Okay, we've covered the theory and the surgery. Now let's get to Part D, anesthetic implications. This is our bread and butter. We've touched on the hyperdynamic circulation, but let's really drill down into the specific systemic effects that are relevant to us in the OR.
Cardiovascular is number one. We've established the high output, low SVR state, but you must also mention cirrhotic cardiomyopathy in your answer.
What does that actually mean? Is the heart failing? It sounds like it's working overtime.
It's a subtle failure. The heart muscle itself is affected by the chronic disease state. It has a blunted systolic and diastolic response to stress. You might see QT prolongation on the ECG, which predisposes to arrhythmias. It means that if your patient gets hypotensive during surgery, the heart might not be able to mount the robust tachycardic response you'd normally expect. It also has diastolic dysfunction, meaning it's stiff and doesn't relax well to fill with blood. It's a heart that looks hyperactive at baseline, but is actually weak and unresponsive when you really need it.
That is a terrifying thought for an anesthetist, a heart that can't respond to stress. What about the lungs? What else is going on there?
Two big concepts you have to know. First, hepatopulmonary syndrome, or HPS. This is the classic triad of liver disease, hypoxemia, and intrapulmonary vascular dilations. Basically, the tiny blood vessels at the base of the lung dilate so much that blood rushes past the alveoli too quickly to pick up oxygen. It's a true shunt.
And what's the exam parole for HPS? The classic sign.
Orthodeoxia and platypnea. The patient gets more hypoxic, that's orthodeoxia, and more short of breath platypnea when they sit or stand up. This is because gravity pulls more blood to the bases of the lungs where the dilated vessels are, making the shunt worse.
And the flip side of that is portopulmonary hypertension.
Correct. This is completely different. This is true pulmonary hypertension, high pressures in the pulmonary artery due to vasoconstriction and remodeling. If the mean pulmonary artery pressure is greater than 25, it's significant. Miller warns that if it's severe, it can be an absolute contraindication for liver transplant because the patient's right heart will fail immediately on reperfusion of the new liver.
Okay, moving to hematology. We know they bleed. It's more than just low platelets, isn't it?
Much more. They have a profound coagulopathy because the sick liver can't synthesize the clotting factors, specifically the vitamin K-dependent factors 2, C-aventinite, X, and X. Plus, as we said, the hypersplenism eats their platelets. But, and here's the modern nuance, the liver also makes anticoagulants like protein C and protein S. In liver disease, these are also deficient.
So they're rebalanced. I've heard this term.
Exactly. They are in a state of rebalanced hemostasis. It's a very unstable balance. The standard tests like the INR might look terrible, suggesting they'll bleed to death, but the patient might actually be prothrombotic because of the lack of anticoagulants. The key takeaway is that the INR is a liar in liver disease. It doesn't tell the whole story.
And finally, the kidneys.
Yeah.
Hepatorenal syndrome. Let's define that clearly.
This is a functional renal failure. The kidneys themselves are structurally normal. You could transplant them into another person and they'd work fine. But because of that massive systemic and splenic vasodilation we talked about, the kidneys interpret the body as being in profound shock. In response, they vasoconstrict their own arteries so aggressively to try and maintain pressure that they end up shutting down their own blood flow and stop making urine.
Okay, so Part D, Section 9, preoperative assessment. You're in the pre-op clinic. Aside from looking for the physical signs we discussed, we need to objectively score them. The Child-Pugh score is mandatory to know, right?
You cannot pass this case without knowing the Child-Turcotte-Pugh or CTP score cold. It's non-negotiable.
Okay, the mnemonic. Pour another beer at 11.
That's the one. P for PT or INR, A for Ascites, B for bilirubin, the other A for albumin, and E for encephalopathy.
Let's look at the nuance there. Why albumin specifically? What does it tell us?
Albumin is a fantastic marker of the liver's long-term synthetic function. It has a long half-life, about 20 days. So a low albumin tells you this isn't an acute problem. This is a chronic long-term failure of the liver's protein factory.
And the PTINR.
Also synthetic function, but it tells a different story. It reflects the levels of clotting factors. Factor 7 has a very short half-life, just 4 to 6 hours. So a prolonged INR tells you about acute or ongoing dysfunction. It's a real-time marker.
In the scoring, how does that translate to risk?
Each of the 5 categories gets 1 to 3 points. Class A is 5 to 6 points. That's a good risk patient, maybe 10% operative mortality for this kind of surgery. Class B is 7 to 9 points. That's moderate risk. Mortality jumps to around 30%. And Class C is 10 to 15 points. This is a high-risk decompensated patient. Operative mortality can exceed 70–80% for major open surgery. Generally, elective shunt surgery is contraindicated in Child's Class C patients. They really need to be considered for transplant instead.
What about the MELD score? Where does that fit in?
The model for end-stage liver disease, it's a bit more objective. It uses a formula with 3 lab values: bilirubin, INR, and creatinine. It was originally designed to predict 3-month mortality while waiting for a transplant. The example here is that it was the first major score to include creatinine, formally acknowledging the huge negative impact of renal dysfunction on survival in these patients.
Okay, optimization. We can't fix the liver overnight, but what can we tune up before bringing them to surgery?
You can do a lot. First, attempt to correct the coagulopathy with vitamin K. It takes a few days, but it can help. If they have tense, massive ascites, you should arrange for a therapeutic paracentesis, tap it. A large, tense abdomen splints the diaphragm and ruins your respiratory mechanics post-op. And if they're even mildly encephalopathic, treat them aggressively with lactulose and rifaximin to lower the ammonia load. You want them as clear-headed as possible before you introduce anesthetic agents.
Now we get to the main event. We're wheels in. Part E anesthesia for shunt surgery. We are in the OR. What are our overarching goals?
We have a few competing goals, and that's what makes it tricky. Goal 1, the absolute priority. Maintain hepatic blood flow. Do not let the liver die on the table. That means protecting that hepatic arterial buffer response. Goal 2, hemodynamic stability. Avoid hypotension at all costs, as it will kill the liver and the kidneys. Goal 3, prevention of massive bleeding. Be prepared for it. And Goal 4, avoidance of any factors that can trigger or worsen encephalopathy post-op.
Let's talk practicalities, lines and monitors. What's the minimum setup?
This is major abdominal surgery with a high risk of hemorrhage. 2 large-bore IVs 14 or 16 gauge are non-negotiable. You should have a rapid infusion device primed and ready in the room. You must have an invasive arterial line. You cannot manage the hemodynamic swings of the clamping phase with a non-invasive cuff that cycles every 3 minutes. You need beat-to-beat blood pressure.
And the controversial one, central venous pressure, the CVP line. Miller is pretty critical of its value.
It is controversial. Miller correctly notes that CVP does not correlate well with intravascular volume, especially in cirrhotics with tense ascites and stiff hearts. However, for the exam, it is a safe answer to state that you would place a CVC to guide fluid trends and for infusion of vasoactive drugs. Just don't get trapped into saying you're targeting a specific number. If the CVP is 12, it doesn't mean they're fluid replete.
Okay, induction. The patient has ascites. What does that immediately mean for my airway plan?
It means rapid sequence induction, RSI. They are a full stomach, period. Creoxygenate, cricoid pressure, no ventilation before the tube is in.
Drug choice for maintenance. This is where the HBR comes back to haunt us. Which volatile agent are we using?
The modern safe choices are isoflurane or sevoflurane.
And why not halothane? That's the classic wrong answer.
Halothane is the wrong answer for 2 huge reasons. 1, the risk of halothane hepatitis, a rare but catastrophic immune-mediated liver damage. 2, and more importantly for the physiology of this specific case, halothane significantly reduces hepatic arterial blood flow. It directly blunts the hepatic arterial buffer response. It takes away the liver's only safety net. Isoflurane is generally preferred because it tends to preserve the hepatic arterial flow the best.
Muscle relaxants. What's the textbook choice?
Cisatracurium is the textbook answer, no question.
Why? What's the magic there?
Hoffman elimination. It's a beautiful thing. It spontaneously degrades in the plasma, dependent only on body temperature and pH. Its metabolism is completely independent of liver or kidney function. It's the safest choice in multi-organ failure.
Can I use rocuronium? I mean, we use it all the time.
You can, and in everyday clinical practice, we often do for RSI. But for the exam, you have to mention the caveat. You must state that rocuronium and its cousin vecuronium rely heavily on biliary excretion. In severe liver disease, their duration of action is significantly prolonged. You might be waiting hours for the patient to start breathing again.
And speaking of reversal, what about Scumadex?
Sugammadex is a great option for reversing rocuronium, but you must again add the caveat. Sugammadex itself encapsulates the drug, and the entire complex is then excreted by the kidneys. If your patient has or develops hepatorenal syndrome, you might have issues clearing the complex. So, for exam purposes, cisatracurium remains the cleanest, safest answer.
Okay, let's go to the scariest part of the surgery, the clamping phase. The surgeon looks over the drapes and says they're ready.
This is the moment of truth. To sew the shunt, the surgeon has to temporarily clamp the portal vein or the splenic vein or whichever vessel they're working on.
What happens physiologically the second that clamp goes on?
You are suddenly cutting off a huge chunk of the body's venous return to the heart. Preload crashes. In a patient who is already vasodepleted due to their low SVR, This can cause precipitous, life-threatening hypotension. The blood pressure can just fall off a cliff.
So how do we prepare for that moment?
Communication is key. The surgeon must give you a clear warning. Clamping in 2 minutes. That's your cue. You verify your large bore IVs are running freely. You might preemptively give a fluid bolus colloid, like albumin is often preferred over crystalloid, and you have a pressor like noradrenaline or phenylephrine drawn up, labeled, and connected to a line, ready to go. You have to catch the pressure before it bottoms out, not chase it from zero.
Speaking of fluids, the choice of crystalloid is a classic Viva trap. Why is lactated ringers, or RL, a potential wrong answer in severe liver disease?
Yes, the examiner will definitely ask, why is lactated ringers bad? The theory is that the lactate in RL requires a functional liver to be metabolized into bicarbonate. If the liver is failing, the lactate can accumulate. This then confuses your clinical picture. Is the patient developing lactic acidosis from sepsis or shock, or is it just from the bag of fluid you're pouring in?
So what's a safe exam answer for what to use?
In reality, the liver has a huge metabolic reserve, and for a patient, a liter of RL is probably fine. But the exam answer is, in severe liver disease, it is prudent to avoid RL. Use a balanced salt solution like Plasmolite because its buffer, acetate, is metabolized by muscle, not the liver. Or you can use normal saline, but you must be cautious about causing a hyperchloremic metabolic acidosis with large volumes.
What about protecting the kidneys? We're terrified of hepatadrenal syndrome.
Right. We need to keep the mean arterial pressure, the MAP, up high enough to ensure renal perfusion. A MAP of 65 is probably the absolute minimum. If the urine output starts to drop, don't just reflexively flood them with more fluids. Check their dynamic markers of fluid responsiveness, like stroke volume variation. If they are volume replete but still hypotensive with low urine output, you might need a vasoconstrictor like terlipressin or noradrenaline to constrict that leaky splenic bed and preferentially push blood flow to the vital organs like the kidneys.
Let's talk coagulopathy intra-op. The patient starts with an INR of 1.8. Do we chase it with FFP until it's 1.0?
No, that's a huge trap. Remember the rebalanced hemostasis. The INR is just one number from one lab test. It doesn't reflect the whole picture. If you blindly transfuse FFP to correct the number, you're giving them a huge volume load, which will increase their CVP, increase their portal pressure, and actually make the surgical bleeding worse. You treat the patient, not the number. Give vitamin K pre-op to stimulate whatever liver function remains. Intra-op, you only give FFP if there's an active microvascular oozing that the surgeon can't control, or if the levels are critically low and you're anticipating a massive bleed. For platelets, the general trigger is less than 50,000.
We've survived the surgery. The shunt is in. Part F, postoperative management.
ICU admission is mandatory for these patients, no question. They need one-to-one nursing and close monitoring. Position them with the head up, propped up to improve diaphragmatic excursion, and watch them like a hawk for encephalopathy.
Why does encephalopathy often get worse after the surgery? I thought we just fixed the pressure.
We fixed the pressure by creating a big detour. We diverted the blood away from the liver. Now even more of that ammonia-rich blood from the gut is bypassing the liver and hitting the brain directly. Also, any blood left in the gut from the surgery itself acts as a massive protein load, which bacteria break down into more ammonia. And constipation is a huge trigger, as it increases the time for ammonia absorption. Keep the bowels moving post-op.
Pain control is tricky. Can we do an epidural? It would be great for an upper abdominal incision.
Usually, no. The persistent coagulopathy makes an epidural a very high risk for an epidural hematoma, which is a catastrophic complication. You are almost always looking at a multimodal intravenous analgesia strategy.
And NSAIDs like ketorolac?
Absolutely not. Never. NSAIDs inhibit prostaglandins, which are crucial for maintaining renal blood flow in these physiologically stressed patients. You will tip them straight into renal failure. It's a contraindication.
So what's left for pain control?
A fentanyl PCA, a patient-controlled analgesia pump, is often the best and safest bet. Fentanyl has no active metabolites that need to be cleared. You should avoid morphine. Morphine has active metabolites like morphine 6-glucuronide that accumulate in renal failure and can cause prolonged sedation and respiratory depression.
Okay, let's list the big complications we're watching for. Part F, Section 14. What can go wrong after a shunt?
The big one, as we've said, is new onset or worsening hepatic encephalopathy. By diverting blood away from the liver, we've traded a bleeding risk for a neurological risk. You also have to watch for shunt thrombosis. If that new shunt clots off, the portal pressure shoots back up and the varices will rebleed, often catastrophically. Ascites leak from the wound is common and can be a portal for infection. And in the worst case scenario, you can get acute liver failure. If the hepatic artery can't ramp up its flow enough to compensate for the total loss of portal blood, the liver just undergoes necrosis.
Okay. Part G, comparison and exam integration. Let's wrap this all up into a package for the student about to take the exam. If I'm sitting down to write that 20-mark essay, what is my roadmap? What's the structure?
It's a classic structure. 1. Introduction. Define TCO and portal hypertension, quoting the pressure threshold of greater than 10 to 12 mmHg for complications. 2. Anatomy and pathophysiology. Draw the diagram of the portal vein formation at L2. Explain the two-hit hypothesis and the resulting hyperdynamic circulation. 3. Preoperative assessment. This is where you discuss the systemic effects like HPS and HRS, and you must detail the Child-Pugh score. 4. Intraoperative management. State your goals with an emphasis on preserving the HABR. Lister monitors. Detail your drug choices, isoflurane, cisatracurium, fentanyl, and dedicate a paragraph to the specific management of the portal vein clamping phase. And finally, 5. Postoperative complications. You must focus on hepatic encephalopathy as the primary expected complication of the procedure itself.
That is a rock-solid framework. Let's do a quick final recap of the absolute essential take-home points for the drive home. PCO is a flow problem that leads to a systemic disaster. The hepatic arterial buffer response is the liver's safety net. Do not break it with drugs like halothane. Hyperdynamic circulation means high cardiac output, low SVR, but an empty tank intravascularly. Child-Pugh. Know it cold. Class A, B, and C. And in surgery, clamp equals hypotension. Be ready for it.
Perfect. And I'll add one final thought. The liver is the body's central metabolic laboratory. When it fails, everything fails. The heart, the lungs, the kidneys, the blood, and the brain all start to wobble. You aren't just treating an organ, you are treating an entire system in a state of controlled collapse.
You know the physiology, you know the surgery, now go ace the anesthesia.
And review that Child-Pugh table one last time before you sleep. Good luck.
See you at the next deep dive.